Now we'll hear from Peter Bach. Peter is the director of Memorial Sloan Kettering Center for Health Policy and Outcomes. He's one of the nation's most respected experts on the cost and value of cancer drugs. Peter's research has improved how cancer care is delivered in the U.S. You can find his writings in the New York Times and in academic journals. And most importantly, I would say that he has this tremendous experience both in the public and in the private sector, mostly in the private sector, but he was also a senior advisor for cancer policy at CMS. He's had real impact on drug prices. An example is after Peter and his colleagues declared that Memorial Sloan Kettering would not offer an expensive new cancer drug to patients because it did not offer sufficient value for the price, the manufacturer actually cut the drug's price in half. So as a physician, he cares deeply about increasing patient access to innovative life-saving treatments at rational, sustainable costs. So I've had the good fortune of seeing him in action, and I can tell you he is having an impact. Thank you, Peter.
Thanks so much, Nancy. So I'm going to talk about drug pricing, but the first half of my talk is an unpaid infomercial for our work, because I don't work at a major respected organization. I work in my office with a couple of people in an entity that we call the Drug Pricing Lab. It's based within Sloan Kettering, which is a big institution. But if you want to look at our work, it's on the web. You can also follow me on Twitter, which I'm required to say, apparently. But here's an example of a little bit of our work. This isn't just in the last couple of years. We've been trying to focus on the pharmaceutical pricing challenges in the US and looking for policy solutions. And part of that is doing the work to describe actually how this system works, and also to take on some of the challenges around claims about this system or why prices travel this way, so that we can better understand good policy. So here's a small snapshot of some of our work. We introduced this idea of indication-based pricing, which both of the nation's largest PBMs took up for cancer drugs. We have sized this question about how much we pay for drugs in the US compared to other European countries, something the president also mentioned last Friday. He claimed that we fund or subsidize research by global pharma. It's true. We estimate in health affairs we actually fund it 1.7 times over, simply by the excess prices we pay in the US compared to other OECD countries. There's other work on here as well. We proposed the idea the government actually buy the company Gilead from the shareholders, noting that the drug was so high priced that this was actually a good deal for the government to pay a premium and buy the entire company rather than pay for the drug itself. We didn't have any takers on that one. Some other things we've worked on, there's the waterfall for that Gilead buyout. We're doing a lot of work on CAR-T. Patrick mentioned a Hep C, an area of interest for us. One of the themes this year we've been trying to work on for policymakers is to understand that you can't look at the prices of drugs without realizing that those prices roll up into budgets. And so people will talk about, well, here's a drug that works great, and if we paid $150,000 per quality, it would crush our budget. That means paying $150,000 per quality is undoable. And so if you want to go on our website, and this got some coverage in the Washington Post as well, we actually illustrated this problem with the state of Louisiana. We put their entire discretionary state budget up online, and you can try, and all of the people who have Hep C in that state and their various insurance programs, and you can try and move the budget around to cover the cost of Hep C treatment, including current discounts and things like that. And you'll see you have to eliminate most programs for the blind, all of advanced education, a lot of other programs that help the poor, just to pay for Hep C in that population. So these are real problems with real trade-offs, and we want to sort of put our hands around it. We've been working on trying to help policymakers understand the distinction between value-based pricing, something I'm about to talk about, and a bunch of things that largely the pharmaceutical industry is advancing as policy proposals that they call value-based pricing, which actually are not about value. And so we've been writing about those as well. I'm going to circle back to this issue of outcomes contracting, one of the things they're pushing as if it's about value. We also have some tutorials on our website that define the sort of arcane inner workings of the system. What's a PBM? What's a DIR payment? What's a wholesaler do? So that you can, if you will, follow the pill, follow the money. The key insight, they don't follow the same path, which is unusual. And so that's in order to sort of understand what's going on, you really do need to understand that sort of basic distinction. We've obviously been following what's gone on with the president's announcement last Friday. We've been trying to keep up. Last week, we posted two things almost immediately. One was an analysis of, in the president's proposal, there's a call for a cut in the hospitals that are eligible for 340B, the drug discount program, something my colleagues and I have written a lot about as being highly distortionary and problematic for the market, but for reasons I can explain, driving consolidation, driving commercial insurance rates up. But in the meantime, the president proposed that hospitals that took care of less than 1% of their population in charity care, I can define what this means actually, should get thrown out of the 340B program. Just so you know, and it's up on our website now, that almost exclusively affects hospitals in Medicaid expansion states. Programs at hospitals or states that didn't expand Medicaid just have larger numbers of uninsured. Another thing that Administrator Verma's been talking about is going after this plus 6% thing in Part B. Secretary Azar this morning talking about the competitive acquisition program, which we're about to post on. That's why I was on my laptop. I apologize for that. But we posted a review of the literature. It is often claimed by doctors that they are not influenced by the fact that this 6% markup leads to a total amount of dollars if the drug's expensive versus a drug that's inexpensive. We posted a review of the literature. It's highly consistent that, in fact, this incentive steers doctors to more expensive prescribing. And just so you know, a lot of people have said, at least in the current administration, a lot of this action is going to happen in the states. I'm a New York State resident, and so following carefully what my government is doing. And one of the things that happened recently was a law was passed that the New York State Medicaid could go through its books and look for drug spending, which was sort of blowing up its program, and then get external assessment of those drugs and how much they should pay for it. New York, this is the first year of the law. New York apparently identified 30 such drugs that were blowing up its budget. They could then go to the manufacturers and ask for additional discounts called supplemental rebates. They did so apparently because when it was all said and done, there was only one drug left on the list. It's the drug Orkambi, made by Vertex Pharmaceuticals in Boston. And the law says they can't just sort of put the screws to the company. They need to get an assessment and ask for rebates down to the value of the drug. They went to ICER, a Boston firm, just a few blocks away from Vertex, in fact, but a nonprofit in this case. And they calculated exactly how much this drug Orkambi was worth relative to its current price. It came out at over $1 million per life year, about $900,000 per quality adjusted life year, because the therapy not only prolongs life but improves the quality of life. It came out as $330,000 per prevented pulmonary exacerbation of cystic fibrosis. I'm a pulmonologist. This is a severe problem for patients with CF, but that is a spectacular number. And ICER recommended actually a range that the state should ask to the drug be discounted down to of about $83,000 per year. Now, just to remind everyone, 5 years ago, if anyone had said any drug was $83,000 per year, we would all be shocked. When I was in residency, I don't want to admit when that was. There was a Medicare program. We had this drug called TPA, which was $1,200, and we had a grand rounds on it, and the difficult ethical problem of giving that versus another drug called streptokinase, which was $80. And this was a controversy, and in fact, the Reagan administration tried to block the paying for TPA because it was so outrageous at $1,200. They failed. But anyway, so it turns out, so I wrote a piece about this, like this is the right step. Use a value assessment, start paying rationally for drugs. Vertex in a conference call basically said, we don't have to by law, we're not giving any more discounts. So just so you know, this competitive acquisition program has now come up. For you, those of you who are following this closely, this is a piece of law that was passed in 2003. It's still on the books. Some of us in this space have been pushing for a relook at this for a while. What this does is it takes hospitals and doctors out of the business of buying Part B drugs, giving them, and then sending a bill for reimbursement with an upcharge. And competitive acquisition, Secretary Azar said, was a way of getting lower prices. So just to review this, this created essentially an intermediary that could buy the drugs and basically FedEx them to facilities that could then use them without taking ownership of them. Back then, the providers had to choose either this CAP program or stick with buy and bill. And at the time, there was little uptake. But what the problems this thing could solve, there's a lot of small practice doctors who say they're underwater for these expensive drugs. This takes it off of their books. It also, if you're interested in value pricing or indication-specific pricing, even some of the things that we generally don't support, like rebate or refund agreements or outcomes contracting, sophisticated intermediaries like CAP vendors could handle all of these things, while the on-the-ground doctors cannot. The risk of diversion is too high. There are some problems it worsens. The original problem with the CAP program was that every single drug that was buy and bill was in there, including bags of normal saline, and it became a logistical nightmare, which is what kept doctors away from it. But the really interesting thing, and the Secretary mentioned it, is if you had a large purchasing intermediary for Part B drugs, could it use its leverage? And using its leverage means denying some drugs, rejecting some drugs if you don't get adequate discounts. And just to be clear, there is a provision in the law which allows the Secretary to then step in if the CAP vendor has excluded a drug in case access to that drug is important. That, of course, is a death knell for actual good competition and it's, if you will, open door for lobbying. But what we've been proposing for a while is that this CAP program, the law allows the Secretary to choose which categories of drugs go into it. This is a distribution of the profits and payments for Part B drugs from 2014 in Medicare. You will see all of the money is concentrated on the right-hand side. You don't have to read the drugs on the bottom. I certainly can't from here. But the idea is actually that this program should focus on these very high-priced drugs, the last 10 or 15 really, moving them into a program we could have category-level negotiation, get rid of the plus 6% markup, have indication-specific pricing, would actually address about 75% Part B spending, and doctors and hospitals can continue to buy lidocaine and normal saline and things like that. So here's the sort of key statement of this problem, just to point out why we are worried about this. Pharma's argument for high prices is you must pay opportunity costs. You have to pay more than the cost of production and distribution. You have to glean rewards down the road to incentivize innovation. In other words, pay much more today, not to recoup the cost of R&D, but as a way of pulling further innovation forward. And it's not wrong, it's just a matter of scale, right? There have to be rewards there for private sector investment. But what are the opportunity costs? And that's what we're trying to get people to see. If you have drugs that are unaffordable, a new innovation that doesn't get to a patient actually doesn't help them. And in fact, that sitting there doesn't help to create the next drug either. We have collapsing insurance structures, although of course we have excellent delivery system here up on the panel. We have a declining value of drugs and we have diminished access. So here's a slide of mine. We track the cost of cancer drugs. Those are the blue dots since the dawn of the Medicare program. And then on the orange, we've tracked the rate of FDA approvals for cancer drugs. Please note they are both going up, but please note for the math geeks in the room, the blue is on the left axis, which is a log scale, and the orange is on the right axis, which is a linear scale. So we're up about threefold in the rate of FDA new drug approvals. I'd argue some of that is a lowering of the bar at the FDA, not actually a rate of new innovation. But on the left-hand side, we're up 100-fold in the new prices of cancer drugs. And this is what is declining value. So this thing in my pocket, I just got the 8 now, which is really awesome. Some of you are probably ahead of that, but I dropped my 6. Value has to do with how much you pay per unit of something relative to what that unit gives you. And I just want to remind people of and I don't want to talk extensively about the iPhone, but you can see the difference between an innovative sector that's delivering more value to us and an innovative sector that is taking value away. The rising blue curve is the cost of the drug Gleevec. This is pre the introduction of generics. We've actually seen about a 63% decline now in the price of Gleevec, now that we have 6 competitors in the market. But since its entry into the US till today, before generic entry, the price of Gleevec went up about threefold for the same pill. Every incremental dollar charged for it is a piece of value taken away from the customer. The iPhone is graphed over the same time period, adjusted for unit of processing power. And you can see that for a monthly contract, the cost of each unit of processing power has actually plummeted. The iPhones we all have today are vastly better than the initial graph. But here's a graph of cancer drugs showing the same general trend. The cost of a life year for a cancer drug has risen from $50,000 to $250,000 in the last 20 years, adjusting for inflation. Along with that rise is an erosion of the core value of insurance. These are the cutoffs in the Medicare Part D program. Also, you can see each of these, even though we say Part D is great, lots of people have access, the cost of being in D and getting through each phase of the benefit has risen, if you will, slipping away from the hands of people on fixed incomes. Here's a graph showing that in the US, when you look at cancer drugs, we actually have the lowest access of any OECD country when you consider the number of cancer patients with respect to the number of drugs they get, but we spend the most per cancer patient even so. We're the only country that has serial problems with people stopping their medications because out-of-pocket costs. We're about, I think it's 6.4. The odds of this happening here is 6.4 times other Western countries. So the idea of value-based pricing is to explicitly and mathematically derive the price of a drug based on the drug's features. It concedes essentially that the market cannot find a value-based price through competition when monopolies are present. It gives prizes for innovation. The big dollars will go to drugs that really, really help people. And in core to value-based pricing is to make patient costs low when prices are appropriate. We had a paper in JAMA, I think, last week laying this out, called Value-Based Pricing, Theme and Variations, and contrasting it to some other ideas, particularly outcomes-based contracts. Now, the idea of outcomes-based, some of this value-based work is done by the group ICER that I previously mentioned that does the most transparent analysis of the value of drugs. And this is a drug abacus icon that we developed with my Bitmoji. And here's the actual drug abacus, which is another value calculator. But since we're short on time, you can read some of the coverage we've gotten. But I want to talk about outcomes contracts because we're generally down on the idea. So the idea of value-based pricing is you take a drug, you look at how beneficial it is, you take its average, you calculate its price, you put it against some quality adjustment estimate like $150,000 per quality. The idea of outcomes-based pricing, which the industry calls value pricing, is to adjust the price after the fact based on the outcomes, but not worry about either where that price starts or how big the adjustment is. So because we're short on time, I'm going to tell you that what this chart shows is that compared to a price for the PCSK9 inhibitor from Amgen, which should be about $2,000 and is about $14,000, the contract Amgen has now offered for outcomes lowers its price to about $13,500. In other words, it just chips away at what is a very big delta between where the drug's price should be and where it is. And this outcome arrangement, refunding in this case when patients have a heart attack, doesn't get you close. We've written about this. The Wall Street Journal's covered this. In Italy, they're a decade into this. They've chipped away at spending with all these contracts to the tune of about 1%. We called this essentially late-night infomercial salesmanship rather than real health policy. But this is really, and just so you know, because we sit in this town, this is also being used as a Trojan horse to push regulatory reform wishes that the industry had long before they ever thought of outcomes contracting. Medicaid best price relaxation because a refund is a zero price. Anti-kickback laws, sending money back to the payer is a kickback, but they want out of that because that's, well, how else are they going to do the refund? And off-label promotion. They want a contract on endpoints that the FDA has said they cannot advertise on. And that's all over this town, and it's actually in some of the recent discussion of the proposal. Thank you very much for your attention.